congenital adrenal hyperplasia, as well as the hypoplasias that cause combined glucocorticoid and mineralocorticoid deficiency, which we covered in the text. And then I think we've already, in a problem set, covered the fact that Gordon syndrome would have variable aldosterone levels. On the one hand, the volume expansion lowers aldo. On the other hand, the hyperkalemia stimulates aldo release. All right, so I think we can finish up hyperkalemia and go on to hypokalemia, if that's okay. Any questions? All right. Okay, so again, I will sort of go back and forth to the algorithm at the top and sort of march through the text with hopefully showing the big picture view of interrogating a case of hypokalemia. Let's do the stuff up top. Including all the way up to, is the kidney responsible or not for hypokalemia? A common theme as you approach many different electrolyte disturbances. Well, first answer the question, is this an artifactual hypokalemia, which can occur similar to artifactual hyperkalemia? It is said that when you have a large number of leukocytes ex vivo in a test tube, they may actually be internalizing K through sodium potassium ATPase activity, and that ECFK be detected as apparently low. Okay, there's some temperature disturbances that can also cause artifactually low serum potassium. The giveaway would be the asymptomatology as well as the lack of EKG changes. Then there's the familiar patterns. Is there a transcellular shift? And then is this a renal cause or a non-renal cause? Okay, so we'll go through that as we go through the differential diagnosis. Before we go to the text, let's just make this point again. Urinary K handling can be interrogated through a number of different tools. Your spot urine K to creatinine ratio is the most common one. The 24-hour urine K can be done. There's the TTKG, which again, I've already stated in a previous week, is probably less accurate than a simple K to creatinine ratio. And that was, again, admitted by the original developers of the TTKG. And then you can also garner some information from even a spot urinary K concentration. A word about that real quick. You cannot make your urinary K as low as you can render your urinary sodium. So teleologically, man evolved in a setting of very low environmental sodium availability, but potassium was everywhere in the diet. And so the kidney apparently cannot conserve K down to zero, essentially, as it can with sodium, right? So you may have some obligatory K loss, even if there is a non-renal cause of hypokalemia. The other point I'll make is that be careful when using a spot K concentration, because if you're quite polyuric, you can have obligatory K loss that is substantial in the urine with because again, you cannot render the urinary K to zero in terms of concentration. And so the high urinary volume, like in a DI patient, can fool you, can look like urinary K concentration is relatively low, and therefore the kidney is not responsible for hypokalemia, when in fact, again, very large urine volumes and the inability to render the urinary K concentration at zero may actually be a meaningful cause of hypokalemia in that patient. Okay, so sometimes you have a bit of chicken and egg phenomenon. Is the hypokalemia causing DI, or is the DI and the obligatory large urine volumes contributing meaningfully to the hypokalemia? Okay, Everybody get that? All right, so urinary K concentrations again, I just made as much point as I wanted to make on that, cannot be rendered zero. Okay, similar to urinary sodium concentrations. Um, Now, once again, as you're trying to evaluate a urinary K to creatinine ratio, you're trying to express that in terms of millimoles, right? Millimoles of K per 1 gram of creatinine. I made the same point in our hyperkalemia tools, so I won't belabor this. If you assume that in a 24-hour period, we excrete roughly 1 gram of creatinine, then this K to creatinine ratio will approximate a 24-hour urine potassium. Okay, so that's the principle when expressing K to creatinine ratios. You got to do a little extra work because this is in millimoles per liter, right? And this is in milligrams per deciliter. So you got to do some math to get the units to cancel out so that you have millimoles per gram as your final units. If you do that, then you can interpret this similar to a 24-hour urine K. All right. Then we'll go through just to anticipate some of the other twists and turns of the algorithms. What's the acid-base status of the patient? Are they alkalotic or acidotic? What's their blood pressure? Those are some of the nodes in the diagnostic path that will traverse as we touch upon these various causes of hypokalemia. All right, so pseudo hypokalemia, I already essentially covered. This is a phenomenon in which sodium potassium ATPase activity in a test tube with really large amount of white cells might cause hypokalemia. Let's move over to the causes of hypokalemia from transcellular shift. Of course, you leverage some of these tools in your everyday practice of hyperkalemia. You give insulin. And so one might predict that that would be a cause of hypokalemia as well, because insulin drives K into cells, stimulating sodium potassium ATPase activity. Okay. So I think that's fairly well understood. Let's keep moving on. We can go through the beta adrenergic agonists pretty quickly as well because you use that tool. And because we've already discussed the inverse already, maybe I'll make another point that individuals who are on theophylline are also at risk for, even though that's a rarely prescribed drug now, but people have even described caffeine overdose. Caffeine is another sort of a natural form of this class of phosphodiesterase inhibitors, essentially. They increased intracellular cyclic AMP activity, inhibiting cyclic AMP deactivation. You remember, I hope, that downstream of the beta receptor is cyclic AMP. And so presumably these are working through the downstream pathways downstream of the beta receptor through increases in intracellular cyclic AMP activity, ultimately resulting in increase in sodium potassium ATPase activity. Okay. And that's largely through the beta 2 receptor, right? Beta 2 receptor is the main sort of effector for stimulating sodium potassium ATPase activity. All right, so hypokalemic periodic paralysis, we talked about in its inverse, that is hyperkalemic periodic paralysis. You'll recall you're going to see some similar through lines between these two. These patients are terribly symptomatic, right? They can even fall over and in attempting to walk or, as they get out of bed first thing in the morning. And remember, that is an individual that is very symptomatic because they are getting hypokalemic They have the perfect storm for um, uh, electrical or for clinical significance of this dyskalemia, because not only is their ECFK decreasing, their intracellular K has increased a tiny amount as well, right? Or at least it's not gone down. Okay. In the Gittleman's patient, you have an individual who has low intracellular K, low ECFK. That reduction in both ICF and ECFK results in less clinical impact, right? But having a low ECFK with a normal to subtly high intracellular K creates a tremendous physiologic significance to that dyskalemia, right? Because intracellular and extracellular K are what your cells rely on for setting, for instance, the resting membrane potential or for repolarization of a cell that has already excited, like a neuron or a muscle cell. We've gone over the action potential, sodium channels opening, potassium channels opening to restore a resting membrane potential that's negative, right? So you rely on this difference between ICF and ECFK, right? So these patients have the perfect storm, a very low ECFK with an ICFK that might be a tad high or at least not low, right? So these patients are very symptomatic. This can be precipitated by rest after exercise. Just think to yourself again what's happening during the action potential, which we talked about, right? You have various channels that are opening throughout the action potential. So you have K channels opening in order for K to leave the cell. So you have all of this flux that's happening. And so it stands to reason that maybe you know, things like exercise can sort of create a instability that sets off a chain reaction that manifests as profound hypokalemia. Okay. The carbohydrate load might be because I'm nudging in the other direction. I'm stimulating with insulin release, the intracellular compartmentalization of potassium, right? I'm stimulating intracellular compartmentalization of that insulin release after a meal. And that might, again, start the snowball of unopposed intracellular compartmentalization of K, resulting in periodic paralysis. Okay. There's a myopathy that's been described in these individuals later in life, interestingly. The pathophysiology, as I mentioned, in hyperkalemic uh, periodic paralysis is not a K channel. So in general, these are defects in sodium channels and calcium channels. Okay, so we have a sodium channel and a calcium channel that is mutated in hypokalemic periodic paralysis. Okay, you can see that this sodium channel is the same channel that is mutated in the other variant, hyperkalemic periodic paralysis. Okay. Um, I've already made this statement describing the precipitant after carbohydrate loads and exercise. So let's move on to the evaluation of these patients. Often we would look for thyroid dysfunction. This form of periodic paralysis has a characteristic feature which I didn't emphasize enough here. You should put it in a note, unless I have it here later on, is that this is often presenting in a Hispanic male. That's the characteristic um, context in which hypokalemic periodic paralysis is most commonly described. Um, and many of these patients have some degree of hyperthyroidism. So it is not that they have some of those patients with periodic paralysis and hyperthyroidism do not have a detectable mutation in a calcium or sodium channel. but many of them do. So it is the case that you have an underlying genetic predisposition, that is the calcium or sodium channel defect, and then you have the precipitant, that is, let's call it the environmental precipitant, that is the hyperthyroidism that sets the snowball in motion. Okay, so again, thyrotoxic periodic paralysis may be from thyroid dysfunction itself, thyroid hormone, which I think we'll talk about here. Yeah, thyroid hormone is, I guess I am making this statement in this separate discussion in the thyrotoxic periodic paralysis. But thyroid hormone can sometimes, again, uh, uncover these mutations in calcium and sodium channels. Okay, or thyrotoxicosis itself can precipitate a periodic paralysis without detectable mutations in these. Okay, so there's some overlap, is what I'm trying to say. Potassium will be exceedingly low, usually in the twos for these patients. These individuals can have some changes in electron myograms. So that was, I would say, a more older way to diagnose some of these. EMG testing was done by neurologists in order to diagnose these periodic paralysis syndromes, both hyper and hypokalemic. But now we're doing more genetic testing, I would say. Okay. Again, there are some provocative tests that one could theoretically do, but because, obviously there's danger to doing that, having someone exercise a treadmill and then go paralytic on you would be, you know, dangerous. So genetic testing is sort of the direction where most people are taken in evaluating this. Okay, so there is a form of this hypokalemic periodic paralysis that is also associated with a predisposition to ventricular arrhythmias. We actually had a patient, I'm forgetting about some of the finer details of the case, but I'll just suffice it to say, even though this really looks very esoteric, we had a patient with, again, this full manifestation of not only the periodic paralysis syndromes, but the underlying QT prolongation and this predisposition to ventricular tachyarrhythmias. Okay, so in any case, this is a separate mutation that's causal in the form that is associated with ventricular arrhythmias. It's a different mutation. Again, usually it's a sodium and calcium channel that's defective. This is actually a defective potassium channel that is underpinning this form of periodic paralysis. Okay. There is also some dysmorphia to the clinical picture as well. Treatment would involve essentially trying to avoid some of those provocative or precipitating factors, that is, these large meals, for instance, with large spikes in insulin. Some also espouse giving a bit of potassium chronically, trying to essentially prevent a hypokalemia where the snowball starts. But of course, in the acute setting and in a patient who has hypokalemia, you're going to want to react with potassium supplementation. Now, the point that is made here is that you got to be careful with potassium supplementation. Obviously, if you see somebody who's symptomatic with EKG changes and has a K of 2 or 2.5, you're going to be tempted to give them large amounts of potassium. Remember, these patients are not total body K deficient. Their total body K is actually in the normal range. And so if you give them a large amount of potassium all at one time, and then that paralytic or periodic paralytic episode relents, these patients can have a rebound hyperkalemia. And so a strategy that is espoused when you're considering this diagnosis is to give small increments of K repeatedly over, 30 minutes to an hour, okay, until the attack is aborted. Now, again, beware of the rebound hyperkalemia that can occur. Remember, however, don't be too worried about that because a person with normal renal function should ultimately be able to dump that extra K. So that should not, and most of these patients have normal renal function. So even if you have some rebound hyperkalemia, it shouldn't be a sustained problem. Okay. We would typically give potassium without glucose. Remember, the typical glucose carrier fluid is in, I'm sorry, the typical potassium supplement given as an IV infusion is diluted in D5W. So you have to be careful about that. If you give glucose, insulin could potentially spike further, and then further worsening of the periodic paralysis and hypokalemia. Again, preventive treatment can involve a little bit of regular potassium supplementation, or even using precipitating a little bit of a metabolic acidosis by giving potassium sparing diuretics. Maybe that also is keeping them a little bit on the hyperkalemic side or on the high normal serum K. But some have espoused the metabolic acidosis itself would potentially be helpful in this in reducing the tendency for K to move into cells, right? K moving into cells would typically be a obviously what we discussed as one of the features for hypokalemic periodic paralysis. But if I have a chronic acidosis and that cation is being buffered by intracellular buffers, my intracellular proton concentration is similarly rising with a chronic metabolic acidosis, this tendency for K to go into cells would potentially be, retarded by a less negative potential difference in the cell. Okay. All right. So let's then go on to this periodic paralysis, and probably we'll end there. The thyrotoxic periodic paralysis. Again, this is typically a Hispanic male. Greater than 90% of them are in males. Hyperthyroidism is the precipitating factor. However, there can also be these other precipitating factors as our prior discussion around periodic paralysis, hypokalemic periodic paralysis, similarly highlighted. Again, so this could be a perfect storm of multiple factors, an underlying genetic predisposition, right? I'll make that point, right? I may have a problem with thyroid responsive K channels, or even again, those channels, sodium and calcium channels that are underpinning the classic hypokalemic periodic paralysis syndrome, right? And then I could have, again, the insulin spike or the catecholamine spike after rest after exercise. That can be other factors that are resulting in this fairly profound presentation. Again, pathophysiology involves intracellular compartmentalization of K. Thyroid hormone is another stimulus of sodium potassium ATPase. We've talked about the insulin effect, the sex predilection, or the predilection for males is not well understood, except for perhaps there being a difference in the frequency of this gene appearing more commonly in males, but why that happens is not well understood. Treatment is typically similar to hypokalemic periodic paralysis, more broadly, is small doses of potassium given frequently, right? And then you can use, obviously, you're going to treat the hypothyroidism. You would do that with beta blockers. If somebody has obvious hyperthyroidism, you reduce the conversion of T4 to T3, right? And then also you're going to treat them with the methimazole, the other drugs that are going to reduce thyroid hormone production more generally. Okay, so yeah, control the hyperthyroidism and incremental increases in serum K. Let me just round out this section. I think it'll be fairly quick to do that. Barium intoxication is basically an inhibitor of K efflux. Okay, so that requires us to just talk a little bit about a concept once again on the resting membrane potential. Remember, the resting membrane potential is established by K moving in the cells, sodium moving out of the cells, with ATP powering that transcellular flux, right? And then what happens is K leaves the cells through some K channels, right? The net result of that is if I bring in a cation and that cation leaves, then the potential difference of the cell with respect to the ECF is negative, okay? Now, barium essentially doesn't inhibit sodium potassium ATPase. It basically blocks the potassium egress here. So barium blocks these potassium channels, allowing potassium egress. The net result is going to be a essentially excess of ICFK and ECFK that's quite low. So it's another form of transcellular shift, right? Now, interestingly, where do we get barium from? It is in some rat poison and then other products, unique products that you might be able to parse out in a very detailed history. But again, that's going to be an uncommon but testable form of hypokalemia. Okay, hypothermia is another cause of hypokalemia, well described. We actually have a couple of cases of profound hypokalemia in the neuro ICU. Sometimes therapeutic cooling is used in the patient who has intracranial hypertension, or at least to avoid the effect of fever on worsening intracranial hypertension. So we've had some patients who've had multifactorial hypokalemia in the neuro ICU because they're often getting barbiturates to prevent the seizure activity. And also that is another way that medical intervention that can reduce intracranial hypertension. So some of these patients in the neuro ICU are the perfect storm. They're on phenobarbital, they're on a cooler to prevent fever-induced intracranial hypertension, and then they're starting to get bronchodilators while they're on the vent. We've had a case of a patient whose K went to ones in that perfect storm, and then they developed severe rhabdo, and their K went to 9. Okay, so in any case, that I think rounds out the transcellular shifts. We can probably stop there unless there's a question.